Unegbu. I am an assistant professor of anesthesiology here at Children's National Health System. I am the lead author on this paper. This study was a combined systematic review as well as a state-of-the-art review, and we really had three objectives. The first objective was really to describe the nature and the scale of the problem, which is pediatric pulmonary hypertension. The second objective of the study was really to try and tackle some of the pharmacologic therapies that are present for this particular disease process. And then thirdly, we then conducted a systematic review that really focused on phosphodiesterase type 5 inhibitors, which are really a mainstay of therapy in children with this disease process. And we wanted to look at the efficacy and safety of this class of medications in pediatric patients with pulmonary hypertension. We had a very rigid format of inclusion and exclusion criteria. We really searched the literature extensively in order to find studies that met our inclusion criteria, which were simply patients with pediatric pulmonary hypertension who were on phosphodiesterase inhibitors. We ended up finding well over 1,000 citations, and after combing through all of those abstracts and articles, came out with about 21 original articles that met criteria for inclusion in our study. So after conducting this exhaustive systematic review, we found that phosphodiesterase inhibitors tend to be overall quite safe, and the benefit of administering this class of medication in pediatric patients with pulmonary hypertension far outweigh the risks. When we looked at the specifics of clinical outcomes in these patients, whether it be exercise capacity or length of stay in the hospital or even the incidence of pulmonary hypertensive crisis, our studies, both the randomized controlled trials and observational studies, demonstrated that we had a definite improvement in clinical outcomes when patients were treated with phosphodiesterase inhibitors such as sildenafil. We also examined hemodynamic outcomes, whether they were obtained by cardiac catheterization or echocardiography. And again, we saw overwhelmingly that there was an improvement in the indices that were measured in patients who were on phosphodiesterase inhibitors, as opposed to whether it be their baseline status or patients who are on a different class of medications. We also were very compelled to look at toxicities, given that high-quality randomized controlled trial that was conducted in 2012, which really left us with some alarming results of increased mortality in patients who were on long-term phosphodiesterase inhibitor by the name of sildenafil. So we looked specifically at mortality data, and with the exception of that trial, the remaining trials that were included in this review, as well as observational studies, did not demonstrate an increased mortality in patients who were placed on this class of medications, which was reassuring to us. In terms of where we go from here, I think clinicians can feel fairly comfortable prescribing this class of medication, especially in the low to moderate dose range for their pediatric patients with pulmonary hypertension. However, we're desperately in need of some additional high-quality studies in this patient population in the form of randomized controlled trials. We also focus primarily on sildenafil. That tends to be the type of phosphodiesterase type 5 inhibitor that's more commonly prescribed, but there are other formulations that are longer acting that may serve as benefit to this population and may improve compliance and adherence, given that you don't have to dose it as frequently. So studies need to be conducted on those other types of phosphodiesterase inhibitors in the pediatric population, because we rely very heavily on adult studies in order and extrapolate the results of those studies to the pediatric population, which isn't always appropriate given that pulmonary hypertension is very heterogeneous and there's a diversity in the etiology of this disease in children, whether it ranges from lung disease to cardiac disease to just the idiopathic hereditary forms of pulmonary hypertension. And lastly, we need to really come up with clinically meaningful functional metrics that apply to our pediatric population, as we cannot extrapolate or utilize adult assessments of functional capacity in children.